just the hospital cleaning lady they all looked down on and dismissed as uneducated help, until a devastating bus crash brought in 23 critical patients, and the overwhelmed ER doctors discovered that Rosa Martinez was a decorated combat medic who had performed life-saving surgery in Iraqi field hospitals under mortar fire. It was 3:17 p.m. on a Friday afternoon at Denver General Hospital, and the emergency department was experiencing one of those rare lulls that veteran medical staff had learned not to trust. The autumn sun streamed through the large windows of the trauma bay, casting long shadows across the polished linoleum floor that gleamed from a fresh mopping. The usual controlled chaos of a major metropolitan ER had temporarily subsided. A few routine cases in the treatment rooms, a homeless man sleeping off a bender in bed 7, and the kind of minor injuries and illnesses that filled the gaps between real emergencies. Moving almost invisibly through this medical landscape was a woman who had become part of the hospital's background noise, as unremarkable and unnoticed as the beeping monitors and humming ventilators that provided the constant soundtrack of modern medicine. Rosa Martinez, 42, pushed her cleaning cart down the hallway with the methodical efficiency of someone who had learned to make herself invisible in a world that preferred not to see her. To the doctors, nurses, and medical technicians who hurried past with their important business and advanced degrees, Rosa was simply housekeeping, a middle-aged Hispanic woman who cleaned up their messes and emptied their trash cans without bothering them with unnecessary conversation. Her plain gray uniform was always spotless, but showed the wear of someone who bought her clothes at discount stores and made them last as long as possible. Her black sneakers were practical and comfortable, the kind that could withstand 12-hour shifts of constant walking on unforgiving hospital floors. Her graying hair was pulled back in a simple ponytail secured with a rubber band, and her only jewelry was a small silver cross that her grandmother had given her 25 years ago when she left for basic training. When the medical staff looked at Rosa, which they rarely did, they saw exactly what their assumptions told them to see. An immigrant woman grateful for steady work, probably uneducated, certainly not someone whose opinions or expertise could possibly be relevant to their sophisticated medical practice. They spoke around her and over her, discussing complex cases and treatment protocols as if she weren't there, occasionally offering the kind of polite but distant acknowledgement you might give to any service worker whose name you've never bothered to learn. Dr. James Morrison, Chief of Emergency Medicine, was particularly dismissive in his interactions with the hospital's support staff. A Harvard Medical School graduate with 15 years of trauma surgery experience, Morrison carried himself with the arrogance of someone who had never learned to question his own assumptions about intelligence, education, and worth. To him, Rosa was simply part of the hospital's furniture, useful for maintaining a clean environment, but certainly not someone whose input would ever be valued in medical decision-making. "Make sure housekeeping gets the blood cleaned up in trauma too," he would say to his residents, not bothering to address Rosa directly even when she was standing 3 feet away. "We can't have the place looking like a war zone when the Joint Commission inspectors arrive next week." If Dr. Morrison had possessed even a fraction of the wisdom that should have come with his expensive education, he might have noticed the way Rosa's eyes automatically tracked the medical equipment being wheeled past her cart. He might have observed how her gaze lingered on trauma cases being brought through the ambulance bay, how she seemed to assess injuries and treatment priorities with the quick efficiency of someone who understood exactly what she was looking at. He might have wondered why a cleaning lady possessed the kind of calm competence around medical emergencies that took most people years to develop. But Dr. Morrison, like most of his colleagues, had never learned to look beyond the surface of people who didn't share his socioeconomic background. What none of them knew, what Rosa Martinez had never told anyone during her 3 years of employment at Denver General, was that those same hands that now pushed mops and carried cleaning supplies had once performed emergency surgery on wounded soldiers in forward operating bases, where the nearest real hospital was a helicopter ride away through hostile territory. Those eyes that seemed focused on mundane housekeeping tasks had once triaged casualties in field hospitals, where split-second decisions determined who lived and who died. That mind that appeared suited only for simple manual labor had once operated on multiple trauma victims simultaneously, while incoming mortar rounds shook the walls and generators provided the only electricity for miles. Rosa Martinez wasn't just any veteran. She was former Staff Sergeant Rosa Martinez, United States Army, 68th Medical Company, with 4 combat deployments to Iraq and Afghanistan, and a Bronze Star with V device for valor in treating wounded soldiers under direct enemy fire. For 12 years, she had been a combat medic, one of the most demanding and life-critical jobs in the military, requiring not just medical training, but the ability to perform complex procedures under the worst possible conditions. She had graduated from the Army's Combat Medic Training Program at the top of her class, then completed advanced training in trauma surgery, emergency medicine, and battlefield triage that was more comprehensive than what many civilian EMTs received. She had worked in field hospitals where a single medic might be responsible for dozens of casualties, where there were never enough supplies, never enough time, never enough hands to save everyone who needed saving. She had performed procedures that would challenge experienced doctors, using improvised tools and limited resources to keep soldiers alive, long enough to get them to definitive medical care. She had walked through minefields to reach wounded Marines, had crawled under enemy fire to drag injured soldiers to safety, had made decisions about resource allocation that haunted her dreams, but had saved more lives than she could count. But that was before the convoy attack outside Fallujah in 2019 that had left her with severe PTSD, chronic pain from shrapnel wounds, and the kind of invisible injuries that made civilian employers nervous about hiring damaged veterans. The Army had given her a medical retirement, a disability rating that provided barely enough to survive, and thanked her for her service before sending her back to a world that didn't know what to do with women like her. So Rosa Martinez, who had once been trusted with the lives of America's finest warriors, found herself cleaning hospital rooms and emptying medical waste containers, invisible to the very people whose profession she understood better than they could imagine. At exactly 3:23 p.m., the relative calm of Denver General's emergency department was shattered by the distinctive wail of multiple ambulance sirens converging on the hospital simultaneously. The sound sent immediate ripples of tension through the medical staff, who understood that multiple simultaneous ambulances meant only one thing: mass casualty incident. Dr. Morrison looked up from the patient chart he was reviewing, his expression shifting from routine boredom to the focused intensity that major trauma cases demanded. "What's the ETA on those ambulances?" he called to the charge nurse. "First unit is 2 minutes out," came the reply. "Denver Fire is reporting a city bus collision with a semi-truck at the intersection of Colfax and Federal. Multiple critical injuries, estimated 23 patients incoming." The emergency department exploded into controlled chaos as the mass casualty protocol was activated. Trauma bays were cleared, surgical teams were called in from other parts of the hospital, and the careful choreography of modern emergency medicine began to unfold with the precision that came from countless hours of training and preparation. But what no amount of training could prepare them for was the sheer volume and severity of what was about to walk through their doors. The first ambulance arrived with a patient who was barely clinging to life, a middle-aged woman with massive internal bleeding from a ruptured spleen, compound fractures in both legs, and signs of severe traumatic brain injury. As the paramedics wheeled her into Trauma Bay 1, Dr. Morrison could see immediately that this was beyond the scope of what his emergency department could handle efficiently. "Get surgery on the line," he barked to his residents. "This one needs to go upstairs immediately." But before the patient could be stabilized for transport to the operating room, the second ambulance arrived with 2 more critical cases, then the third, then the fourth. Within 15 minutes, Denver General's emergency department was facing something that no American hospital is truly equipped to handle: more critical patients than they had doctors, nurses, or equipment to treat simultaneously. The trauma bays were full. The hallways were lined with gurneys carrying patients who needed immediate surgery, just to survive the next hour. Blood was everywhere, on the floors, on the walls, soaking through sheets and bandages faster than the medical staff could manage. The air was filled with the sounds of medical equipment alarms, desperate voices calling for assistance, and the underlying current of barely controlled panic that comes when well-trained professionals realize they are about to be overwhelmed by the sheer scale of human suffering that has just arrived at their door. Dr. Morrison found himself looking at 23 patients who needed immediate, complex medical intervention, and only 4 doctors available to provide it. His surgical teams were backed up for hours. His nurses were running between cases so quickly that proper monitoring was becoming impossible. His blood bank was depleting faster than supplies could be replenished. For the first time in his 15-year career, Dr. Morrison was facing the possibility that people were going to die, not because their injuries were unsurvivable, but because his hospital simply didn't have enough resources to save them all. In the midst of this medical catastrophe, as Dr. Morrison struggled to triage patients and allocate limited resources, he found himself looking at a scene that reminded him of something he'd only seen in war movies or disaster documentaries. The emergency department looked like a battlefield hospital, with patients lined up in order of severity and medical staff moving between them, with the kind of desperate efficiency that comes when every second counts. As Dr. Morrison moved between trauma bays, trying to assess which patients could wait and which needed immediate intervention, he became aware that someone was moving through the chaos with a level of competence and confidence that seemed out of place among the barely controlled panic of his medical staff. It was Rosa, the cleaning lady, but she wasn't cleaning. She was moving from patient to patient with the swift, sure movements of someone who knew exactly what she was looking at and exactly what needed to be done. "Doctor," Rosa said, approaching Morrison with a calm authority that seemed impossible given her status as housekeeping staff. "The patient in bed 12 has a tension pneumothorax that's about to kill him. He needs a needle decompression immediately, or he'll be dead in 5 minutes." Morrison looked at her with confusion and irritation. "I'm sorry, what? You're housekeeping. You can't be making medical assessments." But even as he spoke, something in Rosa's tone, in her use of proper medical terminology, in the absolute certainty with which she delivered her assessment, made him look toward bed 12. The patient there was a teenage boy who had been triaged as stable, but as Morrison watched, he could see the signs of respiratory distress that indicated Rosa was absolutely right. "How did you—" Morrison began, but Rosa was already moving to the next patient. "The woman in trauma 2 needs a chest tube immediately. She's got a hemothorax that's compressing her lung," Rosa continued, her voice carrying the kind of command presence that made people listen regardless of their assumptions about authority. "The man in bed 7 has internal bleeding that's worse than it looks. His blood pressure is dropping and his abdomen is getting more distended. He needs surgery within the next 30 minutes or you're going to lose him." Dr. Morrison stared at this woman who was supposed to be cleaning floors and realized that her assessments were not only medically accurate, but were identifying critical issues that his own residents had missed in their rushed evaluations. "Who are you?" he asked, his voice carrying a mixture of confusion and growing respect. "I'm Staff Sergeant Rosa Martinez, former 68th Medical Company, United States Army," Rosa replied, already moving toward the supply cabinet where the chest tube insertion kits were stored. "I've got 12 years of combat medical experience and 4 deployments treating mass casualty events under conditions that make this look like a quiet Tuesday afternoon. And right now, you've got more critical patients than you can handle, so you can either let me help save lives, or you can worry about hospital policies while people die." The transformation that occurred in that moment was like watching someone step out of a disguise they'd been wearing for years. Rosa's movements became swift and precise as she began setting up for the procedures that needed to be performed immediately. Her voice took on the command tone of someone accustomed to making life-and-death decisions under pressure. Her eyes assessed each patient with the kind of clinical detachment that comes only from extensive experience with trauma medicine. "I need a 14-gauge needle for the pneumothorax decompression," Rosa called to the nearest nurse, who looked questioningly at Dr. Morrison. Morrison, overwhelmed by the scale of the crisis and recognizing competence when he saw it regardless of its source, nodded his approval. "Do what she says," he told his staff. "Give her whatever she needs." What followed was a display of medical expertise that left the entire emergency department staff in awe. Rosa moved between patients with the fluid efficiency of someone who had learned to prioritize and treat multiple critical cases simultaneously. Her hands were steady as a surgeon's as she performed the needle decompression that immediately relieved the teenage boy's tension pneumothorax, probably saving his life. Her assessment of the woman's hemothorax was not only accurate, but led to a chest tube insertion that drained nearly 1 liter of blood from her pleural cavity. Her identification of the internal bleeding in bed 7 resulted in an emergency surgery that discovered a lacerated liver that would have killed the patient within an hour if left untreated. But it wasn't just Rosa's technical skills that impressed the medical staff. It was her ability to maintain calm competence in the face of overwhelming chaos. While doctors and nurses were feeling the stress of too many critical patients and not enough resources, Rosa moved through the emergency department with the kind of unflappable professionalism that comes only from having worked in environments where being overwhelmed was the normal state of affairs, where resources were always inadequate, and where the only option was to save as many lives as possible with whatever tools were available. "Rosa, Dr. Morrison called as she finished stabilizing another patient. "I need you to help me triage the incoming ambulances. Your assessments are better than my residents." For the next 4 hours, Rosa Martinez worked alongside Denver General's medical staff as they processed the largest mass casualty event in the hospital's history. She performed procedures that were technically outside her legal scope of practice, but were absolutely necessary to save lives. She trained nurses on battlefield triage techniques that allowed them to process patients more efficiently. She identified complications and treatment priorities that the civilian medical staff had missed. Most importantly, she brought to the crisis the kind of calm leadership that comes only from having faced similar situations where the stakes were just as high, but the resources were far more limited. As the last of the bus crash victims was stabilized and admitted to the hospital, Dr. Morrison found himself looking at Rosa with a mixture of gratitude and profound embarrassment. This woman, whom he had dismissed as nothing more than cleaning staff for 3 years, had just demonstrated a level of medical expertise and crisis management that exceeded that of most of his residents. "Rosa," he said, his voice carrying the weight of genuine respect and sincere apology. "I owe you an explanation and an apology. I had no idea about your background, your training, your experience. You probably saved a dozen lives today." Rosa looked at the man who had treated her as invisible for 3 years and saw not an enemy, but someone who had simply never been taught to look beyond his own assumptions. "Dr. Morrison, I didn't do anything today that I haven't done hundreds of times before. The only difference was that today, you needed me to do it." "But why?" Morrison asked. "Why are you working as housekeeping when you have this level of medical training? You could be working as a nurse, a physician's assistant, even pursuing medical school." Rosa was quiet for a moment, considering how much of her story she wanted to share. Because civilian medical credentials don't always transfer cleanly from military experience. Because explaining PTSD and combat-related disabilities in job interviews doesn't usually lead to offers in competitive medical fields. Because sometimes it's easier to be invisible than to constantly prove that your non-traditional background is just as valid as someone's college degree. Dr. Morrison felt a wave of shame wash over him as he realized how completely he had failed to see the potential in someone who had been working alongside him for years. "Rosa, I want to make this right," We need people with your skills and experience on our medical staff. I don't care what bureaucratic hurdles we have to overcome. You belong in a clinical role, not pushing a mop." "I appreciate that," Rosa replied, "but I'm not sure I'm ready to go back to that level of responsibility. Today brought back a lot of memories that I've spent years trying to manage." Her voice carried the weight of someone who had seen too much trauma, saved too many lives, and lost too many patients despite doing everything humanly possible. As Rosa Martinez finished her shift that evening and prepared to go home to her small apartment, she reflected on how much had changed in a single day. Tomorrow, she would probably still be the housekeeping staff at Denver General Hospital. She would still push her cart through the hallways and clean the rooms where miracles and tragedies played out daily. But now the medical staff would understand that she was someone special, someone whose presence made their hospital better just by being there. More importantly, Rosa had been reminded that her training and experience hadn't become worthless when she left the Army. Every day that she went to work, every time she used her knowledge to help in small ways that went unnoticed, she was still serving others. She was still using her skills to make a difference, just in a different uniform. And when the moment demanded it, when critical patients needed care that exceeded the capacity of the available medical staff, Staff Sergeant Rosa Martinez had been ready to step forward and do what combat medics do: adapt, improvise, and save lives regardless of the circumstances. Because some skills are too valuable to waste, and some people are too important to overlook, whether the system recognizes their worth or not.